Thanks, Mark. As you said, my name's Phil Ellison, and I work as an extended scope physiotherapy practitioner at University Hospital in Aintree, which is in Liverpool in the northwest of England. And as part of my role, I've developed a heel pain clinic, and I now lead on the management and rehabilitation of patients suffering from Achilles tendon ruptures. So I'm largely here to talk about this research, which was published back in 2017, and what prompted this work, and indeed where we are now at Aintree. I have to say, actually, that some of my motivation to research this area and to develop my own clinic actually came from listening to Anne-Marie talk about her work in Swansea. And I'm very pleased to be able to listen to Anne-Marie again this evening. So looking forward to that. Okay, so we know that there's been much debate over the years regarding the various merits of surgical repair of the Achilles tendon versus non-operative management for Achilles tendon ruptures. And in the hospital that I work at, I'm pleased to say that all of the surgeons were actually in agreement that the non-operative approach was probably the most advantageous for the majority of the patients that we saw in our hospital. And so they gave me the leading role for this part of the service. Whilst I had assessed and also treated patients with Achilles tendon rupture previous to this, this actually gave me a much greater opportunity to see a larger caseload of Achilles rupture patients. And I quickly got the feeling that all was not really as it should be. And whilst the re-rupture rate actually appeared to be quite low, patients really seemed to have great difficulty in rehabilitating to the levels that I thought they should be able to. And although I didn't have any strict data at the time, the majority of them didn't really seem to be able to return to sports or to other high-level activity very easily, or if indeed at all. So the first thing was to set about researching the literature and scoping best practice at other hospitals. The literature clearly showed that the conservative management had become increasingly popular, and that the application of functional rehab strategies had resulted in significant reduction in re-rupture rates. I think long gone are the days when surgical tendon repair shows lower rates of re-rupture comparative to conservative functional treatment. However, focus on the re-rupture as a primary outcome measure meant that other important outcome measures related to calf power, endurance, and indeed to patient-reported function or satisfaction assumed less importance in the light of this. But what I really wanted to get across to people this evening was that tendons that heal and do not re-rupture may heal with lengthening of the tendon, and that can just be as much a concern for us as clinicians or for the patients, as it's likely to result in reduced muscular performance and lower patient-reported outcomes. And it is worth saying, as it says at the bottom of the slide here, that a small amount of lengthening is probably tolerable, and it's possibly inevitable, but any significant length change of the musculotendinous unit cannot be accommodated for. So to ensure that the ruptured Achilles tendon heals at an appropriate length without the use of surgery, we do rely heavily on the ability of a cast or an orthosis to position the foot and ankle in sufficient equinus. And we do have data from cadaveric and from ultrasonography studies that show that severed tendon ends will always oppose each other if the limb is positioned in maximal equinus. But when considering that simple fact, we need to also think about the fact that equinus is composed of movements at the ankle joint and also from the joints of the hindfoot and the midfoot, as is detailed here. Approximately 60% of that sagittal arc of movement comes from the ankle, with the remaining 40% from the subtalar, talonavicular, navicular cuneiform, and first tarso-metatarsal joints. Therefore, we can't necessarily say that a foot that appears to be in equinus actually has sufficient equinus at the ankle joint. And this will become more easy for you to understand and appear when I show you some images in due course. So the majority of studies employing functional rehab describe use of a walking boot, which is generally a fixed angle into which inserts or wedges are placed. And a variety of boots and wedges have been used for this means. This table here just highlights some of the more eminent research studies and the orthoses that they chose within those studies. And as you can see, the Vacaped first appears in Anne-Marie's work in 2015. So moving back to Aintree, my own examination of patients and my review of the literature had suggested that it was likely that insufficient ankle equinus was actually being provided by our customary boot and wedge system, as shown on the left hand side of the slide. This is the one that we routinely used a few years ago, which in turn then was likely to be partially responsible for tendons healing with lengthening, and that this was ultimately resulting in slower rehab and therefore lower patient reported outcomes further down the line. So we began taking radiographs to ascertain exactly what position had been achieved in the boot with the wedges, and then we made comparison of those images to the Vacaped boot. So as you can see here, the aim of the study that we undertook was to ascertain whether two commonly prescribed walking orthoses achieved a satisfactory ankle equinus position. So as far as the methodology was concerned, we selected 10 sequential patients presenting to our heel pain clinic with a diagnosis of acute Achilles tendon rupture. And this was a clinical diagnosis, one of whom was unfortunate enough to have had bilateral ruptures. So we had 11 tendons. Each was managed as per our typical protocol at the time, with 2 weeks immobilization in a non-weight bearing equinus cast, followed by functional rehab, which included 10 weeks in the protective orthosis. The first 5 patients were issued with the fixed angle boot and wedges, and the second 5 patients were issued with a Vacaped boot. Lateral radiographs, as I've mentioned, were taken both following application of the cast and then when weight bearing within the chosen orthosis. The tibio-talar angle and the tibio-first metatarsal angle were measured, allowing us to distinguish between ankle and indeed total equinus of the foot. So with reference to the radiograph that we've shown here, this was actually taken in an equinus cast. Is obviously quite an extreme example, but you can see here that we have lines representing the tibia, the talus, and the first metatarsal, and this allows us to compare the tibio-talar angle to the tibio-first metatarsal angle. Obviously, the tibio-talar angle represents the ankle equinus, which is what we're particularly concerned about, and the tibio-first metatarsal angle represents the combined movements of the ankle, the hindfoot, and indeed the midfoot joints. So as a summary of the results, this table summarizes everything really that we looked at. And you can see, I won't read out all of the facts and figures, but it also contains a control group, which were 10 radiographs randomly selected, weight-bearing lateral radiographs that were selected, just to give us some normative data to compare the figures against. I've highlighted the values for the 2 boots at the bottom of the table. And really, in summary, it's worth saying that the Vacaped produced a significant increase in ankle and also in total equinus when compared to the boot with wedges. As you can see, the mean ankle equinus was some 20 degrees greater. The boot with wedges, it did produce significant change in position when viewed, but it was at the midfoot joints, which I'll show you now on some radiographs. But basically, the only significant findings were that it did plan to flex the midfoot. But as you can see, 28 degrees at the ankle compared to the control group wasn't significant at all. So hopefully these radiographs now, these next 2 slides will really help you to understand what was going on. So these are the typical appearances that we saw. The red lines, again, we've got the tibia, the talus, and the first metatarsal. And the blue lines outline the position of the wedges within the boot. And whilst the foot is certainly plantar flexed, as you can see, the divergent talar and first metatarsal lines indicate that much of that is being achieved through the midfoot and not actually at the ankle joint. So the talus isn't particularly angled downwards or plantar flexed. And as you'll see now on this next slide, quite a different position of the foot. So this image is within the Vacaped, and now the talus and first metatarsal are almost parallel. And that indicates that the equinus position has been achieved through the ankle and the hindfoot joints, not through the midfoot. So you can clearly see on this that the talus is plantar flexed more than it was on the previous image. And again, just to summarize the results, we use this box plot. The box plot shows blue boxes, which represent ankle equinus, and the green boxes represent overall equinus. And basically up to the left-hand side, you can see that the ankle equinus, blue boxes, that's produced by the boot with wedges is only marginally greater than the control group, who were, again, they were weight bearing barefoot. And then there is a significant increase in the ankle equinus produced by both the Vacaped and the cast. And the only real difference between the Vacaped and the cast is in the amount of midfoot plantar flexion or midfoot equinus that is possible with use of the cast. So we concluded at the time that ankle equinus was significantly greater within the Vacaped when compared to the boot with wedges. And the wedges do achieve an overall equinus position of the foot, but this was largely insufficient at the ankle and thought to be due mainly to the design of the wedges, in which the heel pad of the foot rests directly on the flattened top wedge within the boot. So we express caution with regard to the choice of functional orthosis within the conservative management of acute ruptures of the Achilles tendon, as without sufficient ankle equinus during the early functional rehab, our concern was that the injured tendon would heal in a lengthened position, which would possibly result then in reduced plantar flexion power and reduced patient-reported outcomes. Now, I do recognise that there are various wedge designs available. Ours was typically the one on the top right. There are some other designs, but in my clinical experience, all of them appear to suffer from one or more of the issues that I've listed here, which I'm happy to go into in greater detail afterwards if needed. But the other thing to say really is that irrespective of the design of the boot, any fixed angle boot with the insertion of wedges still remains quite a fixed system, and it doesn't allow for an appropriately safe arc of motion during ambulation or during physiotherapy exercise. So it still remains a very limited orthosis in that way. So based on our findings and from research and from scoping what other hospitals were doing, we've adopted the Vacaped wholeheartedly, and we've designed a treatment protocol accordingly for Aintree that suits our purposes and our beliefs. The Vacaped has allowed us to reduce our protected weight bearing phase by 2 weeks, and it's allowed us to use that adjustable range of motion within therapy. And hopefully, again, although I've not got any direct measurements of this, hopefully that dynamization of the boot is helping with the rehab and the results longer term. We do continue to still use an initial 2-week period of non-weight bearing in the cast, followed by the application of the Vacaped, and that's on then for 8 weeks. It's locked, initially for the first 2 weeks, allowing weight bearing but with no movement at the ankle, and then it's open sequentially afterwards to allow full range of movement by the time we get to 8 weeks post-injury. At 10 weeks post-injury, the patient can then begin weaning from the boot, and that's largely based on symptom response and the physiotherapist's discretion. I will typically see the patients back in clinic at 12 weeks, and in the vast majority of the cases, I'm happy for them to discard the boot at that point. Occasionally, they may still require a walking aid. Final follow-up with me is usually at 6 months post-injury. So just looking at where we are now, we adopted the Vacaped boot in 2017 after producing the research study. And just as a little bit of context, Aintree Hospitals has recently merged with the Royal Liverpool University Hospitals Trust, which means that all acute Achilles ruptures coming through to my clinic are now from the whole of the Liverpool area, which has meant an approximate doubling of numbers. There haven't been any significant complications or adverse events that are directly related to or attributable to the Vacaped boot. And patient function, which we're measuring with the use of the ATRS questionnaire, has improved. So I'll finish the talk just by presenting this last little bit of audit data as a summary of the improvements that we've gained as far as patients are concerned with the boot. So again, these ATRS scores are taken at 6 months. For those of you that may not know, ATRS is the Achilles tendon rupture score, and it's based on 10 questions, quite a simple questionnaire for patients to complete. So here we can see that for comparison, we have the pre and post Vacaped boot data. So you can see that there's been an average improvement in the scores of 7 points, which is 18%. And I actually think that the difference may be higher than this if we actually compared the patients a little bit further down the line at 12 months. I think this would largely be due to the fact that the last 3 questions on the questionnaire relate very much to high level function and will likely improve a lot more between 6 and 12 months. but they'll only improve much more in those patients that still have the capacity to build calf strength, to build calf endurance, and to build power, i.e. those that haven't already suffered from lengthening of the tendon. So when comparing, actually, which was quite interesting, comparing the latter three questions only, the patients using the Vacaped actually scored 3 times higher, suggesting that they're returning to work, to social activities, and indeed maybe to sporting activities sooner than the group who'd used the boot with wedges. That's the end of my talk. There's some references attached, but I'm obviously happy to hand you back to Mark now and take any questions if there are any.
Brilliant. Thank you very much, Phil. I think we're going to have to wrap it up for Phil's presentation. What we'll do now is go into Anne-Marie's presentation. Hello, Anne-Marie.
Hi. Okay, so I'm Anne-Marie Hutchison, the consultant physiotherapist from Swansea Bay Health Board. I'd like to thank OPED for inviting me to do this presentation this evening. I'd also like to congratulate Phil on his excellent presentation. I need to declare a conflict of interest in that OPED are paying our health board for me presenting this presentation this evening. I'd also like to thank all members or acknowledge all members of our SMART team in Swansea. Our protocol is a multidisciplinary protocol. It involves all members of the team, from ED to the radiologists through to the fracture clinic staff. I'm fortunate tonight to have our consultant radiologist with us as well, Dr. Suresh Dalave. I'll just introduce him to you.
Hello there.
I will do the presentation, but if there's any questions around scans at the end, then Suresh will be more than happy to answer these. So I've been asked to present our protocol, which is called SMART protocol. SMART stands for Swansea Morriston Achilles Rupture Treatment. Swansea, because that's the name of the city where our hospital is based, and Morriston, because that's the name of the hospital. Everything I'm presenting tonight is in the paper that we published in the Journal of Bone and Joint Surgery back in 2015. So you can get all details of what I'm presenting in this paper. I'm going to go through a little bit of the background of an Achilles rupture and then relate it into our SMART protocol. So as you know, Achilles ruptures are common. They affect more males than females. There tends to be 2 peak incidents. The sporting middle-aged population is 80% of the ruptures, and then the other 20% tend to be in the non-athletic population, mainly patients who are on steroids or antibiotic-induced ruptures. So the aim of our management is obviously we want a tendon to heal, but we want it to heal at the correct length and tension. We want to make sure the person can return to a maximum push-off, and we want them to have limited complications. We don't want a wound breakdown, we don't want a nerve injury, a functional deficit, or obviously a re-rupture. So our treatment options are, we can either manage a patient with or without an operation. This is controversial, as you know. Historically, it's been reported that if a patient was managed with an operation, they had a higher chance of a re-rupture, but less chance of a complication, and vice versa if you were managed with surgery. So traditionally, conservative treatment was reserved for patients who had the comorbidities like diabetes, smoking, and the obese patients. However, over the last decade or so, there's been an increase in the use of conservative treatment, and this is really because of the introduction of a functional approach. So historically, when patients were managed conservatively, they were placed in casts, normally non-weight bearing up to 6 to 8 weeks. But with the new functional approach where the patients are put in the boot, it's quite an aggressive approach to the tendon where we get the patient's weight bearing very early on and we get the tendon moving very early on. And studies from using this approach have shown that the tendons can heal well at the correct length and tension, and the patients can get a good result. These studies both come from animal studies and human studies, which have shown that some mechanical load into the tendon can help increase the tensile strength of the scar tissue. The change towards the functional approach was really pushed by these studies. The one that came out from Canada, where they compared operative treatment to the non-operative accelerated approach, and they found limited or no significant difference between the 2 groups. And then this paper by Wallace in Northern Ireland, where he showed that 949 patients going, or 945 patients going through this functional approach, he demonstrated a re-rupture rate of just 2.8%. So in our health board, we introduced the SMART protocol and this functional way of working in 2008. And this was really based off the fact that one of our foot and ankle surgeons ruptured his Achilles tendon. Since then, we've had another foot and ankle surgeon rupture his Achilles tendon as well. So the SMART protocol has 3 main components to it. Sorry, I'm not sure why that second one has come out as a 1. All our patients have an ultrasound scan. They go through this functional approach and then they all receive supervised physiotherapy treatment. So I'm going to go through each of these components in turn. So the first one, the ultrasound scan. So the reason that all our patients are scanned in our health board, and the reason for the scan is not just to confirm the diagnosis. As you know, our clinical tests have quite high accuracy to them, but it's for the radiologist to provide us with information about the rupture, and for us then to decide whether the tendon is best managed conservatively or surgically. And then if it's to be managed conservatively, what's the best position to put the patient's foot in? So we get the radiologist to fill out this performer, and you'll find this performer in our paper, but I'm happy to share it with you via OPED as well if anybody wants a copy of it. So the radiologist will let us know if the tendon is a complete rupture or a partial rupture. Our surgeons don't operate on any partial tears. The next thing then the radiologist will let us know is where the site of the rupture is. Is it at the musculotendinous junction or is it in the body of the tendon? If it's at the musculotendinous junction, again, our surgeons want to operate at this site since they describe it as stitching the stalk of a pear back into a pear. So it's like the cotton will just pull through at that site. The radiologist will then show us on this transverse view how much of the tendon is ruptured. If it's a small amount of the tendon that's ruptured, we may accelerate the patient through our protocol. They then let us know their level of confidence with the scan, because the radiologists tell us that the later the patient presents, the more difficult it is for them to interpret the scan findings, because there's a massive scar tissue in there then for the radiologist to look at as well. Then the final thing that the radiologist will tell us, which is really important for us if a patient's going to be managed conservatively, is what's the gap size with the foot held in full equinus. What's the gap size? If we can't close it in full equinus or plantar flexion of the ankle joint, will the gap close if we flex the patient's knee and take the pressure off gastrocnemius? And then the radiologist will then let us know also the gap size in the varying positions of equinus. So if we go back to that boot that Phil was talking about, the one with the wedges, that will give a maximum of 21 degrees of equinus. So we'll scan the tendon at 21 degrees of equinus or 20 degrees. And then the Vecoped boot will give you a maximum equinus of 30 degrees. So we only operate on patients who've got a complete tear of the tendon that's in the body of the tendon, and the gap doesn't close, or there's a gap bigger than 1 centimeter when we put the foot down into an equinus position. So all other patients are managed then without an operation. That includes our high activity demand patients. So I'm just going to show you next an analogy of the scan. We've got to jump back and forth the presentation to show you these videos, unfortunately, because of the technical side of this. So you can see here that as we bring the foot up, what we're looking for on this model is do the tendon ends come together. So I'm going to show you this now, next, on an actual ultrasound scan itself. So we'll demonstrate this via a scan. So you can see the gap here between the tendon ends. And as we're taking the patient's foot up, you can see on this patient, the gap completely closes. So for us, this patient would be managed conservatively, and we'd hold their foot in the best position that those tendon ends meet. Okay, we just need to get back to the presentation. Sorry, I've got a few videos in my presentation, and each time we're going to have to jump back and forth, sorry. So for us, the gold standard investigation is ultrasound. Like I said, all our patients will be scanned regardless of activity demand and age. We don't see any indication for MRI scan for these acute ruptures, since we obviously need the dynamic facility of the ultrasound scan. So the next component of our protocol is the functional approach. So for this, all our patients are seen in a physiotherapy-led clinic, in our fracture clinic. So we run this clinic from our fracture clinic, and the reason for this is because the physiotherapists have immediate access to the doctors if they need them for prescribing medication, for example, any anticoagulations that we might need. If there's any wound problems, we can get access to antibiotics, etc. if we need it. The nurses can do the wound care stuff for us, and also for putting the casts on initially, which I'll go through with you in a second. So when our patients are managed with surgery, and I'll go through the figures of how many are managed with and without operations later, they are put from theatre into a back slab, and they remain non-weight bearing for 2 weeks. If a patient is managed conservatively, then as we've just discussed, off the ultrasound scan findings, we are going to put them straight into an Aquinas cast at the best position that brings the tendon ends together. So even if the tendon ends will come together in the position that the boot would hold, will bring them together, we will still place our patient straight into a cast. And the reason for this is that we find in the early stages, it's a lot of information for a patient to take on that they've ruptured their tendon. If we place them in the cast, we know they're safe, they can't take it off, it stabilizes the hematoma. It also reinforces to the patient the severity of the injury, because you'll often find that patients don't complain of a lot of pain with this injury, and they're keen to take their casts or boots off very quickly and get going. For us, if patients have got poor mobility, so elderly people who may have a low activity demand, then we will place them straight into the boot with the wedges. We realise that this will compromise the length of the tendon, but because these patients have got a low activity demand, we find that this increased length of the tendon doesn't actually affect the functional outcome at the end. And we just find that the boot with the wedges is a lot easier for these patients to use. From our perspective, it means less hospital appointments, and it can also, for us, reduce the number of social admissions for these patients. So the majority of our patients, though, will go into the cast. So these are really the middle-aged patients, sporting people who have ruptured, or the high activity demand, elite athletes even. So this is our cast. So the foot is placed in the best position that the tendon ends meet, and then you can see that we put a walking wedge underneath the surface of the cast. So we get our patients to walk on the cast from day one. We'll show you a video of that now. So the patient will spend 2 weeks in the cast. They'll come back and see us in the clinic. Obviously, the cast is removed. They will then be placed into the Vecoped boot. So we're going to show a video of the boot. So for those of you who haven't seen the boot has got a hinge on the back, like Phil described earlier. We place the patients, first of all, into the boot with it locked at 30 degrees. They'll remain in it like that for 3 weeks. Then we gradually unlock the boot over an 8-week period. And we leave the back of the boot unlocked. So as the patient is walking, the tendon can glide. So trying to stop the scar tissue getting stuck to the surrounding tissues. Okay, and then we encourage the patients to fully weight bear in the boot. This is a very aggressive approach to the tendon. in comparison to what happened years ago when the patients were non-weight bearing. But going back to our animal studies and the human studies, which we discussed earlier, so mechanical load into the tendon seems to increase the tensile strength of it. Okay, so we start the patient then doing some early physiotherapy exercises at 5 weeks in the boot. So they obviously take the boot off to do the exercise. So we get them to do exercise for both gastrocnemius and soleus. We ask them to make sure they don't curl their toes, so that they're not using their long toe flexors to do the activity, and that they're using the gastroc-soleus complex. For the elite sports person, I will show you a video. So if you've got, if you're treating elite sports people and you've got plenty of time to treat them, then in the early days you can use this neuromuscular facilitation by placing this onto the tendon to help with the maintain the neuromuscular muscular facilitation of the gastroc-soleus complex. So sorry about this jumping back and forth. So the final component of our protocol is that all our patients receive supervised physiotherapy. So the main rehab problems that we find when the patients come out of the boot is a decreased range of motion to the ankle. It's not because the patients have been in the unlocked VECO-PED boot, you find they've got the range that the boot will give them, and they're just a little bit short of full range. So the range of motion comes back fairly quickly. Once the patient has got equal range left and right, we stop the patients pushing then on trying to regain any further dorsiflexion, particularly because we don't want to over lengthen the tendon in then the rehab process. And then the other problems that the patients get, as expected, is that they're going to have decreased power, decreased proprioception and balance. This is a particular problem for the elderly people. So if you remember, one of the roles of the tendon is to keep us upright, as well as to give us that push off in our step. And then finally, we want to get back the plyometric function, so the hopping, jumping mechanism, particularly for the sporting population. So our rehab aims are obviously to reverse these problems. The details of our rehab plan are written in the paper as well, together with some examples of exercises that the patients can do. So I could talk on each component of our protocol probably for an hour on each component. So this is just a quick run through on each. These are our guidelines that we don't let our patients run, whether they're managed conservatively or surgically, until 6 months. No hopping until 8 months, hill running and returning to most competitive sports till 8 months. For the elite athlete during the rehab process, if you've got access to quite sophisticated equipment, so for example, this Alta G treadmill, so this is a treadmill which reduces the amount of gravity that goes through the patient's foot, then obviously we start with these elite athletes running a lot earlier on in the protocol, because we can reduce the body weight down to 10%. So what's the results of our way of working? So we started our protocol in 2008 when one of our orthopedic foot and ankle surgeons ruptured his Achilles tendon. This bar chart shows the number of patients that were being managed conservatively, that's in blue, and the number of patients that were being managed surgically at that time. So when we first set up this protocol, not all our surgeons were on board with it. And then over the years, by 2012-13, every single surgeon in our orthopedic surgeon took our protocol on board. So you can see by that point, when everybody was using the ultrasound scan to make a management decision on how the patient was best managed, there's only been one patient per year, acute ruptures we are talking about here, who's needed an operation. Now, although there's only one patient per year, you remember the scan is still essential for these patients, because we need to know the best position to immobilize the patient in the boot or the cast. So Our primary outcome measure is our re-rupture rate. I've updated these figures from our paper, so this is now 10 years worth of data. So we've seen 547 acute ruptures and just 6 have re-ruptured. So this is the lowest re-rupture rate that's reported in the literature. 2 of those were surgically managed and 4 conservatively managed. And then most of our re-ruptures are with our rugby players. So that's our national sport in Wales. And it's really because they weren't listening and did things after, when the boots were removed, they returned into drinking on nights out and really wasn't complying with the protocol. And then our second outcome measure is we collect data from our patients. Actually, we review our patients at 4 months, 6 months and 9 months post-injury. So we follow all our patients up till 9 months. That's because we want to check that our patients have returned to sport okay. I've just put the 9-month scores here in the paper. You'll see all our the scores. So the ATRS score, so ATRS is Achilles tendon rupture score. So this is a score out of 100. You heard Phil mentioning it earlier. So our patient score 77 on this, and then on the repair score 73. And again, like with Phil's data, the amalgamated in here is obviously the sedentary patients as well. So they're we lose 30 points on those patients. Just out of interest for you, when you compare our patients who were being managed surgically before to our patients who are now mainly being managed conservatively, at 9 months, you can see that the scores are actually slightly higher with the conservatively managed patients. So we always get asked, yes, but well, what about the elite athletes? Because historically, an elite athlete has always been managed with an operation regardless. For our cohort of patients and our local professional rugby team, if any of them rupture, they'll go through our protocol, and if the scan result comes back that they should be managed conservatively, then we'll manage them conservatively. So I'm going to show you now 2 videos. I've just picked out 2 athletes which have gone through. Well, the first one's a ballerina. Oh no, I can't remember which order they're in. Yeah, so this is a ballerina. This is her at the end of the protocol. She ruptured her right Achilles tendon. She was with the Russian ballet, and then she came over to the UK to teach ballet. She had a complete rupture and was managed conservatively via this protocol. And this is her level of activity that she got back to. And then the next one is our rugby player. So that's him hopping on his injured leg at the end of the protocol. He's managed conservatively. And then this is him hopping on his good leg, just for you to see the difference really between the legs. Okay. So that's pretty much the end of my talk. I think the key message to take away is if you're going to use the SMART protocol, because I hear a lot of people saying that they're using the SMART protocol. I'm not sure they are really, because if you're using it, you need to be following the 3 components of the protocol. So scanning all your patients and making the decision based off the scan result. Then placing the patients through this functional approach, and then the patients going through the supervised physiotherapy. I think sometimes what's happening is some health boards are picking out components of the protocol and then saying that they're using the SMART protocol. But remember, the SMART protocol does have these 3 components, and each component is just as important as the other. So to remind you, everything I've just presented is in this paper. And any questions?
Marie, thank you for a fantastic presentation.